I'll speak now about a case of cardiogenic shock in anterior myocardial infarction patient. So this is a female patient, 61-year-old, presented with inferior STEMI. Her blood pressure at presentation was 85/60, heart rate 120, saturation is fine on room air. Her lactate is normal at time of presentation, RFT is normal, chest X-ray is good. So if we want to classify this lady according to the SCAI shock classification, she is class B shock. So in this situation, the management plan plus primary BCI, of course, we have some tools just to build her blood pressure up. Pharmacotherapy, intra-aortic balloon, Impella, or just nothing to use, no mechanical support. In this case, I thought I can get my case out with pharmacotherapy, as she is in blood pressure is almost 85 and her oxygenation is fine. But one word regarding the inotropic support or vasopressors and inotropic support in cardiogenic shock, it's not 100% safe because survival rate is getting low and low with a number or increasing number of using inotropic support. So if your patient blood pressure is dropping and you are keeping adding 1, 2, 3 more inotropes, just think about doing something else. Do mechanical supports, because we all know adding more inotropic supports will decrease patient survival rates in cardiogenic shock. And if we have to add vasopressors in cardiogenic shock, the data is saying that norepinephrine is recommended, and the data is supporting norepinephrine over dopamine and epinephrine into trials. This is the coronary angiography of the lady. As you can see here, RCA is occluded distally, left system is okay. So primary BCI was done to the RCA immediately. So, but we need to remember always that shock is dynamic. So we need to close follow-up of our patients after revascularization because something may happen in the follow-up. So we followed up the patient in CCU. Her blood pressure was 95/55. Heart rate is 100/30. She was distressed. Her respiratory rate was high. Lactate is reached 6 millimole per liter. Urine output over this 6 hours were diminished. She was in pulmonary edema, and levofit at that time was 0.3 microgram per kg per minute. So an echocardiography was done to this lady, ejection fraction 30%, no mechanical complication, and RV function is good. So if we put her again at this situation on the SCAI shock classification, I think she progressed from stage B to stage C. So now she is doing bad. So, and this is a very nice phone application for cardiogenic shock. You don't have to remember every classification or SCAI shock. This is from my mobile. This is classification or cardiogenic shock from the working group. It can calculate for you shock stage, hemodynamic calculator. I have it and I use it too much. So we love to use pulmonary artery catheter too much in such patients. So we put for this lady pulmonary artery catheter to look for important parameters for her. But what parameters we usually look in the pulmonary artery catheters? Usually there is some parameters to look at and some calculations. Parameters are very simple. Of course, CVB, pulmonary artery pressure, wedge pressure, cardiac output, and mixed venous saturation. Calculations or the calculation we made, it's very important, 3 parameters. PAPI, which is pulmonary artery pulsatile index, cardiac power output, with a very, very important parameter in cardiogenic shock. Cardiac index also is very important. So this is a very, very important in follow up your patient with shock. Some is direct measurement and some is the parameters you calculated, and this application is usually doing it by itself. This is the patient pulmonary artery catheter measurements. Wedge pressure is 25, CVP is 15, output is less, 3.4, index is little, 1.9, PAPI is 1.3, that means RV is good. Cardiac power output is 0.3, and the normal should be more than 0.6. Mixed saturation is low, is only 40%. Phenotyping of cardiogenic shock is very important also to see what are we dealing with. Either we are dealing with left ventricular cardiogenic shock, RV shock, or biventricular shock, and this is very simple things to do. If your wedge pressure more than 18, PAPI more than 1, so it's pure LV. Wedge pressure less than 18, PAPI less than 1, this is RV. Combined if wedge pressure is 18 and PAPI less than 1. For our patients, as you can see here, her wedge pressure is 25 and PAPI is 1.3. That means we are dealing with left ventricular cardiogenic shock in this lady. So what options we have to give this lady more than pharmacological therapy? We think about intra-aortic balloon, Impella CB, and ECMO. We choose to put her on Impella CB as far as saturation is good. So I inserted Impella CP, as you can see here. And again, we shifted her to CCU. And remember, again and again, shock is dynamic. So we closed follow-up here. This is her parameter. Again, after 6 hours after putting her on Impella, blood pressure 95, heart rate is 100/20, lactate is getting up, now it's 80, Livifod is 0.3, but there is no urine output. We add adrenaline to this lady, and she is on pulmonary edema, so we put her on mechanical ventilation. So if we put her again on sky shock, she is progressed from stage C, now she is in stage D, so she is deteriorating at this time. So for escalation in these situations, we have two options. Either put her on peripheral VE ECMO or put her in Impella 5.5, which can give her up to 6 liters per minute cardiac output. And in this case, I choose to go with Impella 5.5 because her saturation and RV is good. So, and as you know, the Impella 5.5, it's a surgical procedure. It should be done by surgeons because her sheath is very big, it's 23 French. So we inserted and we put her in Impella 5.5, and we followed up her also in CCU. As you can see here, blood pressure is better, 100/60, heart rate is 80, lactate, it's getting down up to 1, urine output is good, Livifod now is weaning from Livifod, adrenaline completely stopped, wedge pressure is 12, cardiac power output is 0.9, which is far from the normal number. So now we need to wean her from the Impella. We have a protocol of the weaning of the MCS. We need to gradually reducing P level, and we also continue monitoring the hemodynamic stability, blood pressure, heart rate, cardiac power output, saturation. So all these parameters need to be followed up before removing your MCS. And also be sure she is off of inotropes. Do her echocardiograph to see LV, RV, or whatsoever. This is a very important parameter to see before weaning from MCS. So in conclusion, cardiogenic shock is dynamic. Rapid escalation to MCS and between MCS is the case. In this case of persistent hypotension can improve the end organ damage and to be not late to intervene. Pulmonary artery catheter is very important in my opinion. Thank you very much. Just in
دكتور
time.
مقنع.